Hi, everybody. Welcome back to the Blueberry Pediatric Podcast. Today, I'm here with our awesome Blueberry doctors. This is our second roundtable. I'm very excited to be doing this, where we are talking to you about very relevant topics that come up with a lot of our patients and are very relevant to what's going on right now in terms of illnesses that everyone's seeing, questions that we're getting. So I have, you want to introduce yourselves really quick?
I'm Dr. Monica Davern,
Sure.
Blueberry pediatrician.
I'm Jessica Madden. I'm also a pediatrician with Blueberry.
And Kristen?
I'm Kristen Borchetta. I'm a pediatrician with Blueberry as well.
All right, so we are going to talk today about the flu and norovirus, two viruses, which if you heard me even say it, you might be like, oh, I know, because how could you not know at this point about what's going on? I'm sure everyone's been impacted, if not your own kids or you, somebody that you know, class, people in the class, getting emails home, whatever it's been. So it's been a wild season, kind of rougher than usual, I would say. I'm going to give you a little background information as to like stats that have been going on, and then we're going to dive in. So despite the decline in the flu overall that's present across America, data actually suggests that flu-related medical visits, hospitalizations, and deaths remain elevated. So we still need to be vigilant and learn about it and be cautious around it all. We actually do expect, the CDC expects several more weeks of flu to continue. This season has been classified as high severity. We have not seen these types of numbers since the 2017-18 season. There have been a total of 22,000 deaths from the flu so far this season. Unfortunately, 114 have been pediatric deaths, 16 just this past week. There have been 40 million illnesses, I'm sure more, because now there's home tests and we're not all reporting when anyone gets the flu. These are based on usually it's hospital collection or data from doctors who are testing in office. 520,000 hospitalizations. And the CDC continues to recommend that everyone under the age of 6 months or older gets an annual influenza vaccine as long as the flu is still being circulated. All right, so I'm going to open this up to start discussions. I'd love to know what questions you're getting and like what's most relevant top of mind for everybody.
So I have been getting, I'm just going to throw this out there. What I noticed was earlier on this winter, when families were coming to us with home flu testing, we were seeing a lot of influenza A positivity. But it seems like at some point that's shifted and we're seeing more influenza B. I'm seeing families who are telling me that they had flu A like over the holidays, and now they are going through the round of flu B. So there is a lot of questions about that. Like, is this really possible? Does this happen? We had the flu already. How come we're getting it again? But it's an entirely different strain. I don't know if all of you have noticed this too, unfortunately.
Yeah, definitely. And
the flu A is still like super prevalent. That's the one that took over this year and everyone had for the most part. But yeah, I'm actually going to try and grab the data as we're talking.
Yeah, and there should be some stuff in what we have printed too, but definitely flu A was the prevalent strain this year, and flu B is also circulating. As of a few weeks ago, it wasn't the prevalent strain, but it was certainly on the map. And yes, it is possible to get one right after the other. It's also possible to get both at the same time, although I haven't really heard of that happening. But unfortunately, yes, a lot of families are getting one and then the other one.
That sounds so miserable.
Yeah.
So miserable. Yeah, I'm
sick. I've had a couple and they look pretty terrible. So
yeah. I'm not seeing a huge, I think it's proportionally pretty similar across the board.
Okay.
Maybe a little less than it was prevalent though in the beginning of the flu season.
We usually see like one throughout a certain part of the calendar year and then the other sort of in another phase of the year. It's not super common, I don't think, to see both circulating like this kind of right on top of each other. I don't know.
Yeah, in the past there's been surges where like it's gone down in these weeks and then we see a tick up in March. I'm going to attach a graphic that'll show how wild it's been for this year compared to others too.
Yeah, it's everywhere. It's horrible.
In addition, norovirus, I didn't go into the stats for that, but it's been surging for sure, particularly in daycare centers, schools. There's increased person-to-person transmission is leading to more severe dehydration cases, which is the reason why anyone would end up in the hospital or needing hospital services for getting IV fluids. That means when it's given through a vein. But usually it's a self-limited illness. It's pretty quick. It's just so miserable because it's a gastrointestinal virus, which means it's a stomach bug. There's vomiting, there's diarrhea, could be fever. Kids look particularly miserable. Adults look even more miserable.
Yeah. I think we should dive into that a little bit more, because I think a lot of people think, it's just a stomach bug. It's only going to be 24 hours. My kids are going to be fine. We're going to let it run its course. But I personally am a little bit more aggressive about treating these GI bugs in kids with anti-vomiting medications, because kids are just so much more prone to getting behind. It's like such a smaller system, and it's easier to kind of get out of balance as far as like electrolytes and stuff. And so I think there's like a little bit more we could talk about there as far as what to do if your kid is having these symptoms and why it's important and what they should be drinking and all that stuff.
Okay, great. So let's go with norovirus symptoms. Then let's talk about how to manage, what to do, when to escalate, when it gets dangerous.
Yeah.
And then we can move to the flu.
Okay. I think that sounds good. Does anybody else want to weigh in on this?
So I guess with norovirus and other related stomach bugs, what always throws me by surprise as both a mom and a pediatrician is I feel like my kids, when they get sick, they're fine until they are not. So it's not unusual. It'll be a normal morning. They'll go to school, come home, maybe seem tired at dinner time. And then at least in my case, I feel like they'd always start to vomit like in the middle of the night, like 2, 3 a.m. Yeah. And it feels like it continues. They vomit, they vomit, they vomit, they vomit. It continues on. I don't know if you guys have had that same experience or not, but that's just what I've experienced and seen.
Yeah.
And definitely. And I think this year more than even before, like parents were always like, I thought the stomach bug was only 24 hours. And I feel like people are finally starting to realize that that's not common and it's more. And I feel like especially this year, there's been a lot of prolonged or like recurrent vomiting after kids started to feel better. Like it's been a lot rougher in general.
Well, I think one of the things that one of the takeaways and the patterns that we would see in the ER a ton is that maybe the virus ran its course for 24 to 48 hours, but I think there's an opportunity there to help people manage it a little bit better so the symptoms actually don't continue. So like if your kid is throwing up and throwing up and throwing up, really giving them plain water to drink is not super helpful. They really need to be drinking something with a little sugar and a little salt. And the reason is that kids are just more prone to having their sodium drop and go low. And if your sodium starts to get low, you really feel miserable and you feel like you want to throw up anyway. So sometimes what we would see is these kids that have been sick for like 4 or 5 days come in and we would check their labs and their sodium would be, in the low 130s or even in the high 120s. And so what they really need is electrolytes and a little bit of sugar and salt to just kind of keep everything more normal so that these symptoms actually resolve on their own. But sometimes they just keep vomiting because their sodium has already dropped and all we're doing is replacing everything with water. So like PSA, if your kid is vomiting and having a bunch of diarrhea, they really need sugar and salt. They need like the real Gatorade, not the calorie-free kind. They need something with more in it than just plain water to kind of get things together and get over the hump a little bit better.
I want to actually bring up something that's a really good question for you, Monica. So I don't like Gatorade. I think they got better in what they put in it, but like the artificial the colors like drive me insane. Yeah. What's a better option than that?
I mean, coconut water people really like. There's all kinds of like faux Gatorade now anyway. Really, what I tell people is like, it doesn't really matter. I mean, this is one of those times where if your kid is sitting there with a lollipop in their mouth, I'm not going to say anything about it because they need some source of sugar and some source of salt. It's sort of like the one time they can get out of jail free and drink whatever they want. But as a mom, whatever you want as well is fine as long as it's got some sort of calories and some sort of sodium in it. I think it's better than water.
I agree. It's time to pick your battles, especially around this. If like they're not going to take something because they're miserable and you just need to replenish all the good stuff, like exactly. I guess I have to lower my standards.
You know how I feel about stuff like that anyway, but it like in these
I know that's why I'm bringing it up.
Whatever, like you guys can drink whatever you want, it doesn't matter to me.
Yeah, like juice. It's like the one time where I'm like, fine, have the juice.
Exactly.
Yeah.
And popsicles, I think Pedialyte popsicles are really underutilized. They're like such a great way to get kids to drink when they don't want to otherwise.
Yeah,
Yeah.
exactly.
For infants and young toddlers, I really do like to recommend Pedialyte if they will take
Yeah.
it. The other question I get a lot is when infants and toddlers who are still breastfeeding come down with a stomach bug like norovirus. Breast milk is totally fine. It's good. You can continue to feed them that for sure too, and then just add Pedialyte in for some supplementation.
All right, so we talked about how it presents. I kind of like quickly went through that, but it's the vomiting, diarrhea, fever, being kind of like miserable, tired out of it. Did you guys see anything different than that?
No.
Not
Sometimes they have a
Okay.
low-grade fever. And I do feel like treating
Yeah.
the fever in these cases can really help get them hydrating a little bit better. They're just more cooperative and more willing to do what you need them to do. And so again, it's kind of one of those things where people will say, oh, well, they said that I don't have to treat a fever unless it's 102 or above. It's like, well, if your kid is doing fine, if they look great and they're drinking and cooperating and their fever is 101, sure, you can, you don't have to treat it. But I feel like in my experience as a mom, when I treat the fever, the kid is like brand new and I can actually get them to do the things that I need them to do to get better,
Yeah, and so let's talk about how it's spread, and like why it's so prevalent in daycares.
So norovirus is, it's spread by viral particles that you somehow touch and then somehow put into your mouth. So we generally call that fecal oral transmission, which sounds horrible. And I guess it really is. But it's also super contagious for two other reasons. So number one, hand sanitizer doesn't kill the virus. So you really need soap and water, or what we say bubbles and bleach. So if you're going to clean a surface, make sure it's actual bleach with actual wipes. This is, again, one of those times where if you're a granola mom like me that sprays everything with vinegar, that's probably not going to work. You probably need to get some Clorox going on. And number two, the hand sanitizer that they use at daycare centers, like that's right next to the diaper changing area, isn't going to kill norovirus. You really have to stop and wash your hands with soap and water to get it off of your hands. So those are the two reasons. And then the third reason is actually that, sorry, there's one more, is that it only takes 10 viral particles to cause clinical symptoms, which to me is crazy and almost unavoidable. It's just you're going to end up with it if you're sort of taking care of a kid that has it. There's really no way around it, unfortunately. Yeah.
Right,
Sorry for the doom and gloom again.
Right, totally. All right, so how do we prevent it? How can we help parents to avoid this?
Well, wash your hands with actual soap and water.
Yeah. Yes.
Clean your house with
And
actual bleach, and do your best to try and get your kids
Yes,
to wash their hands as well.
Yes, I always have a box of non-latex gloves, and not only like when I'm cleaning up my kids' messes from this, so I usually will put gloves on, take them off, then still wash my hands, and then repeat every single time. Put gloves on, wipe down the toilet handle, wipe down like every doorknob, every surface. So that's just another thing you can have at home to be able to help prevent spread too.
So I shouldn't have been picking up the chunks of my kids' vomit on the bed and carpet and chairs nearby the beds with my bare hands. Maybe that's why I got it a week later.
The other thing I think people need to remember is that like the diarrhea component of this is contagious for a lot longer than people think. So just because your kid woke up and they're not vomiting today, it doesn't necessarily mean that they should go back to school. It means that maybe you should give them a couple more days and see how they're doing before you send them back into the wild, just out of a courtesy to other families. But it is tough to keep kids home.
Right.
Yeah, for sure. All right, and then you brought up a good point before, Monica, about what the meds that we give out to help with them to get hydration in and avoid ER visits and all the bad stuff that can happen. So there are medications that we use that stop the nausea from coming on Dantatron, Zofran, you might have heard of it. And every doctor practices a little different, has a different threshold for when to give it. What are your thresholds? Kristen, you want to go for this one?
Yeah, I'm Probably similar to Monica, I'm very proactive about giving it. I mean, if you vomited once and you're fine drinking fluids, fine. But otherwise, I think it's always worth one dose. Move on with your life, keep fluids down. So I tell parents a lot, like at least reach out as soon as they're vomiting more than one time so that we can evaluate. Don't wait until they're behind because then it's just really hard. So,
Yeah.
Yeah. How do you know that they're behind? So parents can have an idea of like when they should worry.
yeah, so not making tears when they cry, mouth, lips looking dry, no drool in little babies, not urinating well, so like peeing less than 3 times a day. Those are the main things. Sometimes excess sleepiness, which can be hard because they're already tired from being sick. But those are the main ones I usually tell people to watch out for.
Yeah. I also like to tell people to schedule it. So
other-
like generally our practice at Blueberry and in the ER settings is to give 24 hours worth of the medication because it's helpful for 2 reasons. So it's a treatment obviously, and it can help things get better, but it's also a diagnostic tool. So if you give your kid Zofran and 2 hours after you've given it, obviously the dose has gone in, they're still vomiting and they're still miserable. To us, that's sort of an easy threshold to say, okay, well, now it's time to escalate and go in. Obviously, our intervention didn't work. So I like it for that, but I also like to schedule it. So like if I'm going to do 3 doses, I think personally it's a lot easier to prevent the next episode of vomiting than to respond to it once it's already happening. It just saves everybody a little bit of trauma. And thankfully, the nice part about Zofran is that it's generally a really safe medication to give in kids. It actually, the risk profile goes up in adults because it's the biggest side effects have to do with cardiac stuff. And most kids don't have any heart issues yet, thankfully. And so I'm pretty like liberal with giving it. It can also be used off label if your kid is going to the bathroom like every 10 minutes and you can't get the diarrhea to stop. It can be used to slow GI motility and get the diarrhea under better control so that everybody can kind of focus on hydrating instead of, spending the whole day in the bathroom. So it's a good medication.
It is. I'm a little different in my prescribing behaviors. I would say I don't time it or give a full 24 hours right off the bat. I usually will make it available in the prescription I'll write. But I do find that one dose is enough to, if depending on when it's given, like if they're already behind and it's really relentless, that's different. But if they're not really behind and the kid's willing to try and drink, one dose I do find is quite effective, and then you don't need the rest. But having the rest in their possession is very helpful. I think also adds to peace of mind.
Yeah. It's one of those medications that people hoard and take on cruise ships and things.
Right.
So,
yeah. So if you're scheduling it, so I usually say like every 8 hours while they're awake. Monica, do you have parents wake up at night if they are asleep during when it's the 8 hour
No,
mark?
I do exactly what
do
you do.
Them
I do every 8 hours while they're awake for 3 doses. The other pro tip for parents is that like if your kid is vomiting all day, please don't wait until bedtime to reach out because that makes it really hard for us to help. Ideally, we would be able to intervene when they're awake during the day. We can give this medication as soon as we realize that things are going south, because then it'll stop the cycle of vomiting and give us a chance to really get them to drink during the day. The cases that sort of break my heart are the ones that like, okay, this has been going on for 2.5 days. The kid won't stop vomiting. They've only peed 2 or 3 times. And now it's like 9 o'clock at night. And we know for sure we're not going to make any headway overnight because the kid is going to be asleep. So pro tip is just reach out early, don't wait. It's okay. Well, we're happy to help,
Mm-hmm.
And it's also a lot harder to get the meds overnight. A lot of areas don't have 24-hour pharmacies. And so a lot of times you're stuck waiting until the next day.
The morning.
Anyway.
So. Yep, very true.
Right.
Yeah. The practice in peds when you're training is like 4 wet diapers in 24 hours is sort of like the minimum threshold. I consider that, I tell people like, okay, that's passing grade, but it's kind of like a C-. Like 4 times in 24 hours for a kid it's not great, right? Like they could be doing a little bit better. So really it's when your kid drops below that we are kind of in more deep water, right? So I would say keep an eye on wet diapers. If you're getting close to 3 or 4, that's good, but still room for improvement,
Yeah, I think it's a bit of a gray area too because it's a big picture too. It's How are they looking? Are they willing to drink, but maybe are drinking less? So if it's less than 4 wet diapers, but you have a kid who's like up and going and is fine after vomiting twice, but isn't so happy to take food, but will take, I think that that's also reassuring. And, it's not like a red flag. It's like a yellow tinted one. So it's like the whole picture together is what matters. And this is like why pediatricians are able to decipher when it's why you reach out. We can tell you when you're heading into that true red flag territory.
Yeah.
All right. We went through a lot of the stats. Presentation, let's start with that. How do they usually show up? How have they been with flu A?
Yeah.
Oh my goodness. High fever, usually a decently high fever, fatigued, they are tired, sore throat, headache, some coughing. That's what I've been seeing is the pattern. I'm sure there's other symptoms.
And this year I've seen a lot of, not just body aches, which is normal, but a lot of dizziness in older kids. Everybody's dizzy.
Yeah. And then it generally comes on, hits like a ton of bricks. The fever can last. We generally don't like a fever that goes on more than 4 days, but in the flu, sometimes we do see it. But then the post-viral myalgias this year have been really bad. So that's like the muscle pain after the flu where the kid is so sore that they don't want to walk. I don't know if we want to talk a little bit about that because I feel like we've been getting a lot of questions lately about what to do.
Yeah, it's scary. Your kid doesn't want to walk.
It's scary, right? It really is just the muscle breakdown that can happen after having the flu, like similar to if you had just run a marathon or something, your legs would be really sore. And these kids have had such high fevers that their body is sort of in the same state. And the answer is just to hydrate them like crazy and to help flush all that stuff out. Sometimes I'll send them in just to get like a urine and check a level of muscle breakdown to see how high things are. But most of the time the answer is just hydration and just getting them to, to get through it and to flush things through.
All right. And transmission, like how and why are kids getting this so much?
So contagious because it's the droplets in the air and contaminated surfaces. So it's everywhere.
Right. So just like breathing makes you susceptible.
Exactly.
Yeah.
And you're contagious even for 24 hours before the symptoms even start. So they've already spread it before you know to keep them.
Right. And then it's up to 7 days after onset, which is quite a long time.
Right. And of course, we let kids go back to school when they're no fever and feeling better, but it's tough. They may still be contagious at that point.
Yeah. Right.
Yeah. I feel like it's keeping a lot of kids out of school for about a solid week this year because it's taking that much time for the fever to resolve and clearly for all symptoms to get better. So
and just to have the energy to go back to school.
Yes, I've been encouraging families that if their child's overcoming the flu, if they're on the edge, like I don't know if they should go back or not today, I've just been saying let them rest that one last day and keep them home overall. And do we talk about the home flu test yet?
No, we should. This is new.
Because they're new.
We should talk about all that.
Yeah. So this is the first year that over the counter, there are combined flu A, flu B, and COVID tests that are available. And you can buy them at just about any drugstore, pharmacy, or retailer like Target or Walmart.
And Amazon.
At Amazon, yes. I've only been recommending the iHealth brand because it seems like that one's easy to find and everywhere, but there are multiple different brands too. It's very similar. It's just the same process as running a COVID test. Just really important that for whatever specific test you purchase, follow those instructions to a T because it can be a little bit different in terms of how many drops you use and how many swirls you do. And typically we get results in about 10 to 15 minutes.
I'm sure all kids are so willing to do that swab after the trauma of COVID swabbing. My kids are a mess with that. They like anything go. I show them a Q-tip and they're like, no.
Yes, this is my life. Exactly. And I think it's worth saying too. I think a lot of the questions that we get, it's like you can also presume that everybody has the same thing. So if dad tests positive for flu and all of a sudden everybody has a fever and looks miserable, we don't need you to test everybody. It's okay. We can actually treat and start antivirals on the presumption that everybody in the household has the same thing. You don't have to put your kids through that. You don't have to spend the money on the test. And I think we can talk about kind of the nuances between who we treat and who we don't. But I will say I've never have been a strong advocate for Tamiflu in my practice before all this. I always kind of thought wishy-washy about the data, but this year our ICU colleagues, the people that are the physicians in the intensive care units and stuff, are seeing such severe significant flu that they're actually recommending that we do start Tamiflu more liberally than we were before. So
What about
And I think,
Zofluza?
yeah,
That's
I love
like a newer
Zofluza. If
one.
you can find it and your kid can take a pill, it's awesome.
it's really tough though because a lot of insurance doesn't cover it because it's new. I mean, we're like what 6 years later, but and it's really hard to find. I mean, I live in a major city and I couldn't find it in 40 miles when we had the flu last year. So it's worth trying, but I think it's so important that parents know that if we're going to treat, that we really need to treat early as soon as possible. And so, number one, don't wait to reach out if you think your kid has the flu, because if they need the meds, you want to get them started. But also, when I prescribe Zofluza, I really tell parents, like, if it's not covered, it's really important that we know right away, because we want to make sure that we get you in still within that time frame if we have to change to a different medicine.
And so we want to prescribe it within 48 hours of the onset. Right. And if it's later than that, do you prescribe?
Depends.
The recommendations are that if the child is at risk for severe disease, so like our kids with asthma, immune deficiencies, that yes, you should start it at any point if they're still sick. But for a healthy kid, no, not after the first 48 hours. I don't.
Okay. And the goal of it is not to, it doesn't like make it magically disappear, but it'll lessen the severity and shorten the course. And hopefully kids will feel better quicker.
Yeah.
Right. And in kids who are at high risk, I mean, some studies showed like up to 70% reduction in admission to the pediatric ICU for severe complications.
Yeah, that's huge.
So Zofluza, can you do it prophylactically the same way you can for Tamiflu?
You can.
Okay. So
only in certain populations.
Got it. Okay. So for people that are listening that aren't as familiar with this, Zofluza is new. It's the newer sort of version of Tamiflu. Actually, I guess it's not that new. It's like Kristen said, 6 years old, but it's only available in a pill form now. So now's the time to teach your kids to swallow a pill if you can. With sprinkles is the way that we did it at our house. It worked magic. It's such a great thing to teach a kid how to swallow a pill. But with Tamiflu too, like you can treat preventively. So like if one of your kids was exposed and now is having symptoms, you can actually treat everybody in the household with Tamiflu to try and prevent the spread so that people don't end up developing symptoms at all. So that's kind of a helpful tip too. If you're wondering about an exposure, you can absolutely reach out and, Tamiflu is an appropriate medication for that.
It's a different dose, right?
Yes, it's a different dosing interval.
It's different timing. Yeah, same dose.
Yeah. Right.
It's once a day for prevention and twice a day for prevention.
Yeah. All right. So prevention, this is a big part of flu, like unlike norovirus. There's no vaccine, but there is the flu vaccine. We give it annually to all children who are greater than 6 months old. The first vaccine for anyone getting it, you need 2 rounds, but from then on, it's just once a year, and it's available by that injection or the nasal.
The flu mist.
Yeah, flu mist.
The mist. Thank you.
Which is for 3 and over.
Thank you. Yes, and is contraindicated if they have a history of asthma.
And we should talk about that because I think people get really frustrated. Like, oh, I got flu shots for everybody in my house, and here we are with flu A, and then we have flu B. And it's, I understand the frustration, but I think what people don't understand is that the influenza vaccine has never been intended to prevent people from getting influenza. It's always been intended to prevent people from dying from influenza. So you're less likely to get severe disease that requires hospitalization, that poses a risk of death. Unfortunately, the vaccine does not prevent anybody from getting it. I wish that were the case, but that's just not, like, when we talk about the efficacy of the vaccine or did the vaccine work, we're not looking at whether or not people got the illness. We're looking at how severe their illness was.
And that's actually something that we didn't talk about earlier that we probably should talk about is, again, why influenza? Like, why is there a vaccine? And what are those complications that you're working to give the vaccine to?
Oh, yeah. Let's talk about that.
Yeah.
Okay.
I think probably most people think of like the common ones, right? Like ear infections, pneumonia, which is a lung infection. I mean, those are by far the most
Sure,
common ones.
dehydration.
But there are more severe ones that we need to think about.
Yeah. So the flu actually makes like other more virulent bacteria like worse. It kind of opens the gates to the body's immune system to say like, hey, come on in, you know? So I've seen really severe cases of group A strep, for example, which is the strep that causes strep throat. You can have invasive group A strep. And a lot of the times flu is sort of the gateway to all of that happening. And so it's really important that we do our best to prevent severe disease. And that's kind of the point of the vaccine, is to help people kind of bounce back quickly so that they don't develop these complications that can be more severe.
Right. And although rare, things like brain and inflammation, encephalitis, and myocarditis, which is a weakening of the heart muscle. I mean, those are really things that we want to make sure that we're doing.
Yeah, but again, bacterial pneumonia, I think you said that earlier, Kristen, is like a more common one, but that could be very dangerous.
Very, yeah. Right. And I feel like we've seen a lot of pneumonia from flu this year compared to other seasons.
And that's another thing too for families to know, if their child's recently has the flu or recently had it, and then at any point in that illness develops like a new high fever again, or really seems like they're taking a turn for the worse, like either day 3, 4, 5, 6 of the illness, that's really important at bare minimum to like reach out by phone to a pediatrician, or to have your child seen again in person to make sure they're not developing a secondary infection related to the flu.
Yeah, and it's because it's confusing, because the flu can cause a fever for a week on its own, but to decipher whether your child or the patient is getting sicker from a super infection caused by bacteria secondary to the flu is a tough one to figure out. An exam truly does help with that. Imaging, like an X-ray, can help with that. Looking at the ears.
Yeah.
If there's an ear infection on top of it, very common.
And this year is extra confusing because I feel like more than ever we're seeing they'll have fever for like 3 or 4 days, and then they do seem to improve, and then the fever comes back, and so we're sending a lot more of those kids in, even though some of them they go in and they don't find anything else. Sometimes they do, but it is a weird pattern that we're seeing this year. It's just worth mentioning.
All right, so let's talk about the basics of treating this. Like, forget all the complications. Most kids do usually pretty well with this. We have to support them with the basic stuff at home. What is that?
Okay. So basically the same as you would for any other virus, but just expect things to be a little bit more intense with the flu. So they're going to want to rest. You're going to let them nap. You're going to wake them up and make sure that they're drinking. Make sure that they're peeing at least 4 times in 24 hours, more if possible. They may develop the body aches. They may develop vomiting and diarrhea. Really hydration and treating the symptoms is key. So you can also contact us for Zofran in the setting of the flu. Plenty of people end up needing that.
Yeah. Advil can help with soreness, Tylenol, but for fevers, all of that. It just helps them feel better to get the fluids in. And sometimes it helps you also like diagnostically to know that they're okay, because if a bacterial infection, they might just be knocked out completely and not get better with the Tylenol and Advil. And I think it sort of helps to know if the day, do we need to go now? Is it more serious to be seen in person versus like, we can wait it out. This is just because the kid has a bad fever.
We should talk about that. That's a question we get all the time. So like, is there a height of the fever that we have to rush to the ER? No, there's not. We really care more about the duration of the fever. So if it lasts more than 4 days, you need an in-person visit. And if the fever is not coming down with the appropriate doses of Motrin and Tylenol. So, if it's not coming down, but you haven't given anything, the first step is to always give the appropriate dose and see what happens. And other than that, we just kind of let it ride until till day 5 or so. If it's still there on day 5, then we would want you to be seen.
Yeah. And to kind of hammer that home, I always tell parents, like, the temperature is not dangerous until you're hitting like 107, which is not going to happen in like a regular healthy kid, right? So, and even so, like, you can hit 106 and probably still be okay if it comes down, but just because people really want some kind of number reassurance. So,
well, I think it's harder.
I don't know. I still freak out at 106. I personally,
it's
at 106, just as a mom, I freak out.
I think it's reasonable, but I also have to say, like,
you're 105.
We would call those temporal thermometers in the ER random number generators, because they're they're like accurate, but they're not precise. So you can check. We had a kid in the ER that hit, oh my God, is registering 106. And the kid is like sitting there, he's hot, but he's fine. Like that kid didn't have a fever to 106. Like it might have been at 102, 103. And so they will accurately detect the presence of a fever, but the actual number actually isn't really very accurate. So I would say just use your mom instincts or your dad instincts. You know, your kid has a fever, yes, but try your best not to perseverate on the exact number, because I would say in 99% of cases, it doesn't really matter as long as it's improving with medicine.
I don't even take my kid's temperature most of the time.
I don't either. Unless I'm trying to figure out if they can go back to school or not.
Right. Well, there's that. Yeah. You look at the kid, not the number.
Exactly.
There's another thing I wanted to bring up too, just about flu treatment at home, because I have a lot of parents ask this question. So say that you are in a mode of that you're very strictly limiting screen time for your kids, okay? Or you're in a mode of parenting life where you're very cautious, like their nap time should be from this time to this time, and their bedtime is from this time to this time. When they're sick and have the flu or a virus like this, those screen time rules, they can go out the window. They just need to rest, okay? So that's okay. You know, we always say limit it to like no more than an hour or 2 per day. But if they're sick with the flu laying around, it's okay. At least I think it is. The second thing is they need to sleep more than usual. So if your child's sick with a flu or similar virus and their naps are longer than normal, that's okay. If they're sleeping in later in the morning, that's okay too. That's their body just needs to rest and recover. And so I just wanted to make sure to bring that up. If everything is very strictly scheduled, it's going to go out the window when they're sick. And it's also going to take a little while for that to normalize as they get better too.
Yeah, absolutely. I'm in agreement. A little more leeway for them to just relax and to make it easier on you too as a parent, because it's very stressful and very hard. And maybe you're working from home trying to do it all at once. Like something's got to give, let it give. This is the time.
Absolutely. I used to joke with people that whenever mine had a fever, like she would know, she'd be like 2 and she'd look at me and say, McDonald's, because she knew that was the only time that I would get fast food and whatever, you know, like whatever.
That's really sweet. I do want to bring up one treatment that we know about that's more on the holistic path, though there's evidence behind it. It's called, and I can't really pronounce it correctly, oscillococcinum. How'd I do?
You got it.
I know what you're talking about. Yes.
I don't know how to pronounce it either. I don't know.
Yes. So there is, Kristen, do you want to walk us through the evidence?
Yeah. So there were some studies from the NIH that studied it in adults, of course, and it did show that it could reduce the duration of the flu by, I think it was like 0.3. So like a third.
0.3 days?
Yeah, which, you know, Tamiflu is only like 12 to 24 hours in some studies. So it's not that much different. It did show some like possible prevention data. So it was promising that there may actually be some benefit, but the study was small and it basically said that it wasn't conclusive enough to recommend across the board, especially in kids, because they didn't really study that. I don't know if there are more studies going into it.
I'm looking at the one that you're talking about, Kristen, and actually it shortens the duration of influenza by 0.28 days, which is similar to Tamiflu. So that would be like what? Like 6 to 8 hours. So
right.
You know,
it's pretty close.
Sure.
So
is it FDA approved?
Let me check.
No, because FDA doesn't study any of these meds. So.
Right. So that's just a point I want to make to go along with that, is that if, you know, there's no way to regulate, it's very hard for us pediatricians to get on board with them, because there could be different dosing in each amount that a kid takes, or there's not real recommended. Actually, it's just, it's still a gray area, and it's not as concrete as the well-studied drugs.
Yeah, exactly.
Right. Yeah.
I mean, it was worth adding that there were there's other stuff going on. RSV still an issue. Rhinoenterovirus still an issue. COVID still an issue. Still adding to all these respiratory-like illnesses that could show up just like the flu as well.
Absolutely. Yeah.
Hopefully, kids are getting outside a little more starting this week. I don't know. The Northeast has been miserable with weather, but hopefully everything will start declining pretty soon.
Yeah.
Yeah, it always does, right? It always does.
Yeah,
I
I
just
feel
can't
spring
stand
break
I
is
feel like
traditional,
the
like
spring break
the
reset
area where we
sometimes
see the
helps,
drop in the graph is like always around. It's coming. Like the end is hopefully near. You know.
Mhm. Yeah. All right. Thank you, everybody, for joining. Hope this was helpful. Please send us questions if you have any. We are here for you 24/7 virtually to take care of your kids, of you, and your mental health for anything you need.
Bye,
Bye.
guys.
Bye, guys. Thank you. Bye.
Thank you all for tuning in to today's episode. Be sure to subscribe to the show for more episodes. And if you love the show, if you haven't already, please be sure to leave us a 5-star review.